So today, for our May professional development meeting, we have a very interesting and timely program and topic on supply chain resilience and resilience in general. And as you may know already, but our speakers are Daniel Stanton and Dr. Matt Acampora, excuse me, Matt.
That's all right.
MD. And many of you probably know Daniel. Uh, he's a supply chain educator. He's a member of the Apex Charlotte chapter. He wrote the book Supply Chain Management for Dummies. He's also a frequent lecturer and trainer on LinkedIn Learning, where his courses have been viewed more than 1 million times. Daniel is an IBM Watson supply chain futurist. He's a pros to know from supply and demand chain executive. He earned his master's from MIT and master's in logistics engineering, and he's currently working on his doctorate at Cranfield University. Dr. Acampora is a primary care physician at Welcome MD here in Charlotte, located at the Arboretum in South Charlotte. He's done work at Hackensack University Medical Center, and he taught at Yale School of Medicine, and he's been in Charlotte for a number of years. So I'm going to turn it over to Daniel, and I may have to drop off before the end, but Daniel, you just take it away, and at the end, everyone, please feel free to ask questions. Thanks very much.
Awesome. Jim, thank you so much. I really appreciate it. And I know, this is a challenge for all of us, figuring out how do we keep our Apex chapter together and build our community and keep doing the professional development stuff that we need to do while physically distancing and socially isolating, and also, by the way, either doing our jobs or looking for a new job, because this is really just a time of crazy change. So I don't know that this is the new normal, but I think doing a Zoom PDM is a good move towards agility and adaptability. So thank you much for having me. And Matt, Dr. Acampora, thank you so much for joining. What we're going to talk about is we're going to talk sort of broadly about supply chain risk management. I'm going to share a couple of tools that I use a lot in my training to help people put together supply chain risk management programs in their companies and for their supply chains. And then we're going to talk specifically about the risk of COVID-19, this new coronavirus, so that we have the information to really build good risk management strategies and mitigation plans, and at the end of the day, create more resilient supply chains. The one thing that I'll throw in, Jim, I really appreciate the introduction. I should mention that along the way in my career, I spent some time in the military, and of course, there's a lot of risk management sorts of stuff associated with that supply chain. But I also had a chance, I spent 2 years while I was at Caterpillar creating the very first supply chain control tower, which was all about how do we anticipate the things that could go wrong in our supply chain, how do we get visibility to them, and how do we respond to them quickly. And so, I'll just say, that thought process, it's a part of the way that I approach supply chains. And I'm really seeing it being useful with the situation that we're experiencing today. So with that, let me start with the slide about the beer game and the bullwhip effect. And Jim, do you remember, when was it that we did the PDM over at Domtar where we played the beer game? That's probably 1.5 years ago now.
Yeah, Daniel, that was, I think, September of 2018.
Wow, perfect. And if for folks that were there, you'll remember the whole point of the beer game is to teach people about the bullwhip effect. about how easily a small disruption in the supply chain can create these ripples or these bullwhips where, at one point in the supply chain, you've got stockouts and you're desperate to get replenishment, while at the same time in the same supply chain, somebody else is just drowning in inventory, right? And between the beer, the brewery, and the retailer in those four steps in the beer game, you'd have all of these extremes and all of this stress and tension. And it really happened over the course of maybe just 25 rounds, I think, is about what we played. So that is a behavior that supply chains have. It's well known, it's been modeled, it's been studied, and we are seeing it in spades around us right now. What I think is interesting about what we're seeing with COVID-19 is it seems like we're getting disruptions both in the demand side and on the supply side. So, I want to talk a little bit first about the demand disruptions, because it seems like we're seeing three different kinds of disruptions on the demand side. The first type is where the demand has shot way up, but the consumption is actually flat, right? And so I think, the toilet paper is the example that we're all looking at, where you're just like, we're not using any more toilet paper. Why are we having such a hard time keeping up? Well, yes, I mean, there's some issues there with, the product mix is different, right? Because we've gone from, using toilet paper in the office or in restaurants to now it all has to be at home. So that's really a different supply chain. But we've also had, a very different buying pattern, and that's made it hard. It's created one of these bullwhips. The second kind of disruption that we're seeing on the demand side is where demand is up and consumption is up. So I think, this is the case with N95 masks and with Lysol wipes. And, the issue there is we're using more than we were using before. So it isn't just a question of, sort of waiting for the bullwhip to settle itself out. We actually need to be increasing the capacity of the supply chain, right? We need to be making more. We need to have more transportation for that stuff. We need to have bigger distribution facilities. We need larger inventories. So where we have those disruptions, where the demand is up and the consumption is up, we truly need to scale up the supply chain. But one of the challenges there is we're going to have to overshoot the actual demand, right? We don't know what the new level of demand is. We just know that it's more than what we had before. And the way that we're going to find out that what the new level actually is by increasing capacity beyond that, and then watching stuff start to pile up. And then we're going to have to scale the capacity back. So the risk there is that we could have a really big overreaction when in fact what we want is sort of a moderated overreaction, so that when we know that we've hit that point where the real demand is at, then we can stop and back it off slowly. The third kind of disruption that we're seeing on the demand side is where the demand is down and the consumption is down. And I think anything having to do with entertainment, sporting events, concerts, great examples of that, right? There are supply chains there. There were people that had contracts to ship in food and paper plates and sponge fingers and all of that stuff. Now the consumption has dried up. And so, for the folks that are working in a supply chain where your consumption is gone, it's a new world, then the challenge is, can we sit on stuff? Can we hold it in inventory? Is it perishable? If it's perishable, how could we change that? How could we reroute that, redistribute it so that it doesn't go to waste, so that it gets used productively before it reaches the expiration date? So those are the three different patterns that I'm seeing on the demand side for disruption. The bigger one that I'm concerned about, and I think this is likely to be an issue for many, many months to come, are supply disruptions, right? So there are factories in China that were shut down for a month for the Chinese New Year, and then got shut down for another month or two because of COVID-19. So, there likely are, 3 months there in which they produce nothing. And now, even if they're able to open back up, it may not be at full capacity. They've got a whole lot of back orders that they're going to have to deal with. There's going to be a lot of scrambling for capacity. When I translate that, down to, anybody that's trying to build a complex product that has a lot of components that go into it, it's likely that at least one of the components that you need is going to somehow be disrupted. And, reflecting back to my days in the manufacturing world, if you need 10,000 parts to build a tractor and one of those parts isn't there on the day that that tractor needs to come off of the line, well, guess what? You don't have a finished tractor, right? And so, even though a lot of, statistically, it looks like a lot of the production, especially in Asia, is coming back online, the odds that one of the parts that you don't need is going to be unavailable are really, really high, right? The more components there are that go into the things that you make, the bigger the probability that you're going to be missing at least one of them. So that's the disruptions, or the category of disruptions that I'm really kind of concerned about as we're moving forward now, or the supply disruptions. I think this is part of the CSCP study material, but there is actually an ISO standard around risk management. It's really more focused on business continuity planning, sort of, looking inside the four walls, but it applies just as well to the supply chain if you want to use it there. So they have a formal process, a formal standard that you can go through. I like to make sure that people are aware of that because, some companies use that, and in some environments, like you may have customers that ask you to comply with ISO 31000. So there's good stuff there. I have, a kind of a simpler approach that I tend to use, and that's really what I want to talk through. But real quick, before we get to the process of managing the risks, the thing that I do want to say is, when you find a risk, when you're looking at a risk, it turns out you've really got a pretty limited number of options, right? And how you should deal with a risk oftentimes is a function of how severe the impact would be and how likely the probability is. So I should have had the citation on here. I apologize. This is out of a book. But this author had said, for for low probability, high impact risks, what you should do is transfer those to somebody else. Basically, buy insurance. Write a contract that says somebody else is responsible for handling that problem. You're transferring the risk to them. For low probability, low impact risks, you can accept them. That's just part of doing business. High probability, low impact risks, just, make sure that you've got visibility and you try to keep it under control. In the upper right quadrant, high impact, high probability risks, just do whatever you can to avoid them. And then for everything else, mitigate it, right? Mitigation meaning do something to either reduce the impact or to reduce the probability. So that's kind of the standard approach to a risk management process and a risk treatment strategy. When you look at the research about supply chain disruptions, this graph shows, an example. The blue line is a disruption that's managed well, and the red line is a disruption that's not managed well. It's just a graphical way to show what I think all of us know intuitively, which is if you're prepared for it, it will still impact the business, but you're going to be able to recover quickly and get back to your normal capacity. Whereas if it catches you off guard, you're likely to suffer much more severe disruption, and it will take you a lot longer to get back to your original capacity. All right, so the two kind of quick systems that I have, the first step is preparing for a disruption, right? And so this is a nice 7-step acronym, and this is something that really I like to do with a team, right? With the supply chain team. What are the risks that we're concerned about? What's possible? How would they impact the business, right? What results would they have? Can we put some numbers around it and estimate what that impact would really be? And can we estimate what the probability is? How likely is it to occur? Once you've got that probability and the impact, you can come up with a risk score, and you can rank things, right, based on the probability times the impact. Then decide how we're going to respond. And a lot of times that decide how you're going to respond actually becomes a document, right? It can become your crisis management plan or your risk management strategy, whatever you want to call it. And then you need to educate your team about what's in there. And there's some pretty good examples out there. Cisco is one of the better examples where they had done this. They'd gone through the process of evaluating their risks and putting together a handbook. And sure enough, I think it was the floods in Thailand that when that flooding occurred, they were basically able to, pull their handbook off of the shelf and know exactly which suppliers they needed to contact, what additional capacity they could buy and where it was. And they were able to, be really flexible and adaptable to respond to that and minimize the impact on their business. So prepare, this is, my approach to getting ready, right? What do you do so that your team has a plan for when a disruption occurs? The second one here is, what do you do when you need to respond, right? Because a plan is nice, but you can't anticipate every risk, and you can't anticipate exactly the way that it's going to hit you. So direct is an approach that I use for leading projects. And, the response to a disruption is a project. So the first step is define what's the challenge that you're going after, investigate your options, resolve to your course of action, your plan, right? Which could be straight out of your risk mitigation strategy, or it could be an adaptation of that. Execute that plan, change over the system, meaning if you need to switch out software, if you need to move from one facility to another or open up a new facility. And then the last one is transition the people, right? That's really the, making sure that folks are making the journey with you instead of having it done to them. So I think those two pieces, the prepare and preparing for the disruption and then directing the response, really are the things that we as supply chain professionals need to be thinking about right now. Either, we're not facing it yet, but we need to prepare, or, oh crap, it's happened. Now let's direct that response. So this is the approach that I take, and I find it's a pretty quick and easy way to get everybody on the same page and move it forward. All of that, in the moment we're facing COVID-19, we really need to be concerned about that because the probability is really high and the impact is really high. But, if we take a step back, you say, we live in a world where supply chains are becoming more complex. These big disruptions are more frequent, right? There's something every year. By the way, it looks like hurricane season is starting early for us this year. And so, you have to look not just at one disruption and the frequency of disruptions, but also now that, what happens if they happen concurrently? And then the other one that we always need to be thinking about is becoming a more pervasive problem is cyber threats, right? Getting hacked. Somebody gets your email, somebody gets into your system, gets your customer's credit card information. That becomes an important part of supply chain resilience too. So that's my supply chain resilience spiel. Now what we want to do is drill down some more and share actual facts, data, real life experiences about what's happening with COVID-19. I'm so grateful to my friend and our family doctor, Matthew Acampora, for making the time to join us, because I think you guys are probably in a similar situation. I mean, we see a lot of stuff on the news and a lot of absolute BS on social media that is actually getting in the way of us figuring out what do we need to do to protect and prepare ourselves, our families, our teams, and our supply chains. And so, having a medical doctor here to talk about, what we've really seen, what the doctors are doing and thinking about and advising, I think is just, hugely valuable for all of us. So with that, Dr. Acampora, please.
Thanks, Dan. Thanks for having me. It's a great opportunity. I enjoy speaking in front of everyone. The COVID pandemic to say it's an understatement is an understatement. So the thing is, I just want to go over a few things with you today, hopefully that you understand. And if you have any questions, I want to make sure that you have my contact information. I know Dan can provide that for you. I'll be more than happy to answer any questions. When it comes to the history of coronaviruses, there are basically 7 coronaviruses, 3 that we're probably very, very familiar with personally. Those are the ones of the common cold. But the SARS-CoV-1 virus, which basically hit us in about 2000, 2003, was probably the first of the virulent viruses. The problem with the COVID-1 was that, yes, a lot of people did die with it, but it declared itself and it didn't vie its path in either direction, as did the MERS virus in 2012. However, now with the with the coronavirus, the SARS-CoV-2, the virus causing the COVID disease, it's not declaring itself. So when we talk about symptoms, that evolves on a daily basis. So we went from basically a upper respiratory type tract viral condition where we had cough that more likely was dry than productive, where we had fevers that were high, 103, 104, to other symptoms such as loss of sense of smell and taste, conjunctivitis, inflammation of the lining of the eye with infection, even things like dizziness, loss of balance, which is again a common viral condition that we see in a very common condition that we see with viral illness, has also been shown. So the thing is, but the one major factor that definitely I think pervades amongst all of the symptoms is the fact that it produces an overwhelming fatigue. That's what we're seeing a lot of. So people with overwhelming fatigue, again, are thought to maybe having COVID. And again, you have to prepare for each, as Dan promptly stated, you have to prepare for each of these because everyone today who comes into your office, you have to assume may have COVID. And then you have to take those necessary precautions in order to rule that out, number one, but in order to protect your patient base and in order to protect your staff as well. Dan, if I could have the next slide, I would appreciate it. In terms of treatment and progression, again, that's evolving, okay? I think the one basic thing is if you know someone who has been exposed to COVID or someone who may have been exposed to someone who is exposed, quarantining, self-quarantining is shown to be very good. I think we're imitating what went on in 1918 with the Spanish flu, and they had tremendous success with quarantine and social distancing. I think we're doing the same, we're seeing it. Unfortunately, there are no treatments right now. However, there are many clinical trials that are going on throughout this country and throughout this world, even in Charlotte. I believe we have about 14 clinical trials that are ongoing looking at various treatments. They seem to be looking at things like immune modulators that we see in treatments of cancer disease that have been showing some effect. We've seen mention of the word remdesivir, which is an antiviral agent that has been used actually in the Ebola outbreak and in HIV disease. So again, these are medications that, again, are part of clinical trials. They're not peer-reviewed as of yet, so I express extreme caution in terms of entertaining the use of any of these things. We've seen the word hydroxychloroquine, a very, very potent drug with a tremendous amount of side effects, especially in people who do not need it. So I would be very, very careful in venturing into that realm. However, once people have been exposed to the disease, it usually takes somewhere between 3 and 5 days of mounting some kind of response, you may be symptomatic with some of the symptoms that I mentioned, but you and I could be having a casual conversation, and my viral load in my nasopharynx, my nasal passages in my throat, is extremely high. And here I go and I cough or sneeze and infect you, and you come down with symptoms that I may not come down with. So we have to be really very, very careful in terms of our ability to take histories from patients who may have had some exposures. Those people who do require intensive care unit, a lot of them are receiving ventilator management. Interestingly enough, from a respiratory standpoint, people describe an effect where they actually feel better lying down than they do sitting up. And it's been an odd presentation. But again, we have to keep all of these in mind as we approach these patients. In terms of other issues, I think that, in terms of medications, thinking outside the box is important. And I know Dan is aware of this, my colleague, my medical director in Richmond, Neil Carl, related the story recently of a colleague of his in the Richmond area who returned from London, where he picked up his daughter who was traveling there with her college, with her university. And basically what they did was he came down with COVID and developed respiratory compromise rather fast. So rather than treating the viral disease itself, the physician in charge of the critical care unit basically went and treated the symptoms that the virus was producing. So apparently there was a high level of what is called interleukin-6. Interleukin-6 antagonists were given, and within a period of 72 hours, this person went from being close to being placed on a ventilator to going home. So the thing is, I think that we have to also think outside the box as well when we are looking at options in terms of treatment of these patients. Dan, if you can hit the next one. In terms of what we have available, the cultures, I think, are the mainstay. We've been doing in our office nasopharyngeal cultures since day one. So are those patients of ours who did have symptoms that were suggestive, the ones that I mentioned? Yes, they did receive cultures. We were lucky. No one has turned positive, thank God. Antibody testing is, again, very, very highly discussed in medical circles as well as others. There are very few antibody tests that are approved right now, but there are many that are going for approval. We do have antibody testing in our office. I think it's going to be an important part of what we do as this whole situation continues to evolve. But testing for antibodies, I think you're going to probably develop antibodies within 8 to 13 days. Roughly 91% of the people who test positive via culture develop antibodies within that period of time. Most, though, you'll see within 14 to 21 days. Antibodies tell us that you're basically mounting a response. You've been exposed to the virus. You may or may not have had symptoms, but now you're mounting an immune response. The trouble with that is we don't know whether that confers lifelong immunity or not. And with the way this virus is presenting, your guess would be as good as mine. In terms of prevention, I think common sense is the great approach. And panicking just produces more panic. I think one of our presidents in the past said the only thing you have to fear is fear itself. And I think that definitely applies here with our approach towards COVID. Soap and water, it's there, it's the best. The only thing I recommend is I wouldn't use soap that's outside of my own home, because again, I don't know where it's been or who it's been with. But soap is probably and water is probably the best preventative measures that we could use. So I frequently use soap, and water figuring out my day here in the office. I could probably grate cheese at the end of the day with how dry my hands are. If you don't have access to soap, though, definitely hand sanitizer is the best. Make sure that the hand sanitizer has at least 60% alcohol or more. It's proven to be effective at that point. Physical distancing, social distancing is, I think, definitely very, very important. I think it's a reason why we haven't seen more and more cases and maybe more and more deaths. I think, and time will tell as we continue to venture into the phases, if we keep to the physical or social distancing, how important that may be to us. In terms of cleaning, I think that, again, common sense. I mean, in our office, from day one, we enacted simple principles. Our patients are not allowed into the office until they meet with me outside the office. Temperatures are taken, masks are given, gloves are given, and then the patient is allowed into the office. If the patient has a fever of 100.5 or above, they're not allowed in the office. They're instructed to go back into their car, at which point they will be tested, depending upon what their symptoms are, but fever is a big one. We automatically test them. After each patient is seen, the room is cleansed, the table is cleansed, the surfaces are cleansed. We wear masks throughout the day. And especially when our patients are here in the office. So simple, common sense type approaches, I think, will work as we continue to progress. In terms of PPE, I think it's very important, especially for those people who are on the front lines and those people who have a risk for development of the disease. So the thing is, our nurses, our doctors, especially our ER physicians, our physicians who are hospitalists, our nurses, they should have definite access in terms of when they're treating people with signs and symptoms of the disease in order to prevent them from getting it, but also in order to prevent the people who they are seeing from coming down with the disease.
So, go ahead, Matt.
Oh yeah, no. In closing, I'd like to say that I think a common sense approach is the best. I think that you have to identify those people who are at risk, who are with you or around you. We're doing that in our office, and I think if we do that, I think resiliency, collaboration, and education, I think, will prevail, and we will definitely get a hold of this.
I was going to tack on to that, Matt, just because, you and I had this conversation about 2 weeks ago where, we got to the place in our house where we said, we're doing what we can to try and prevent it, right? The kids are home, we're washing our hands all the time, we're disinfecting everything before we bring it in. But the reality is the odds are that at some time in the next year or so, one of us is going to get it somehow, right? And we probably, while it's good to delay it, right? Because the longer we can wait, the more time there is to develop treatment options and for the doctors to know how to handle it better. The other thing, though, is we want to make sure that we're prepared for, okay, what is the plan, right? What do we need to watch for and how are we going to respond to it? And so that, that prompted this conversation between Matt and our family to say, okay, what are the symptoms, right? What are the indicators? And then what should we do? And part of that is a supply chain guy is, okay, so how many days of inventory do I need to have on hand so that none of us have to leave the house or go shopping and do all of that? And how are we going to quarantine inside of the house, keep the healthy ones separate from the sick ones? But out of that process, we realized that step one in like every one of those scenarios was call Matt and most likely, I think what we'd be doing is driving to your office. You guys are doing the nasal swab testing, the culture in the parking lot. So like you guys will put on the hazmat suit, we'll roll down the window. And so we've even got that part planned out now of, okay, assuming that this were to happen, what would we need to do? And do we know who to call and how to do it? And, I'm sure that there are lots of people that look at it and say, Daniel, you're a freak. No real people in the world do that kind of stuff. But I actually think that's really what we should all be doing, one for ourselves and our families, but also the equivalent of that for the office, right? What would we do if Billy or Sally shows up tomorrow and says, I just got a call and somebody that I know had it and we were hanging out over the weekend? What do we do, right? Do we have a plan in place for how we're going to handle them and everybody else in the office? Matt, I don't know if you have anything else that you wanted to add to that, or if we want to open it up for questions and discussion.
No, I agree with you 100%. As he pointed out, we had the conversation. I mean, and I'll just add another story onto that. I was pumping gas into my car, and I had a Clorox wipe, and I was pumping down the handle and the face plate where I put my credit card and pressed what type of gas I wanted. And the gentleman behind me said to me, he goes, is that really necessary? I said, well, if you like to live, I said, it may be. I said, and I explained to him who I was, and I just, sat there with him for maybe about, 5 to 7 minutes, educating him on why. And he wound up borrowing a Clorox wipe from me. So the thing is, preparedness, I think, is, again, common sense approach. You've got to prepare. It's why everybody's running to the store when the hurricanes are to get milk and bread. But so the thing is, you have to be prepared. So I really think it's an important part of what you do and what I do.
Agreed. I think we're on the same page there. All right, so I'm going to put, you know what? I've got the branding up here. I should have put the phone number and the address, but I'm happy to share that if anybody needs it. But with that, let's kind of pause, because typically the way it works in a PDM like this is you share some information and then other folks hop in with what they're seeing, what they're doing, or any questions that they've got. So.
Okay, great question. First of all, masks are really designed so when you wear them, you're protecting everyone else around you from getting a possible infection like COVID to protect the other people. You're not really protecting yourself that much if you do have the disease, but if the other person is wearing a mask, you're definitely protected because they're wearing a mask. Are they efficacious? Well, again, that's depending upon the type of mask you're talking about. If it's a regular surgical mask, can coronaviruses penetrate those masks? There's nothing to show that they can't, but you'd have to be in really close proximity to someone coughing or sneezing for that to happen. But I think it's been shown to be a protector in the past, and I think it's definitely efficacious. Definitely efficacious. As I said, we do them in our office. In public, I'm wearing a mask. If I go to any store, I'm wearing a mask. Someone asked me if I'm exercising, should I wear a mask? And I'm probably not the best person to answer that question because of my exercising habits, but I know I probably couldn't wear one because I'd be way too short of breath. Interestingly enough, though, if you do wear a mask and you go see your physician, make sure you take it off for about a minute or so before they take your temperature, because you're breathing into the mask. You can be, misjudged as having a possible fever. So that's another thing. But I think masks are very effective.
Matt, one of the things that you and I had talked about, and I don't know that we really got to it in the conversation here, is that one of the challenges with this virus is that when you catch a virus, it reproduces in your body, and that becomes the viral load, or sort of the amount of virus you have, right? Mm-hmm. And it seems like the viral load for this coronavirus ends up getting really, really high before you actually have symptoms, meaning that the people that actually have it, have a high viral load and are able to spread it, don't have a clue. I mean, they really have no reason to think that they're hurting anybody. And so that's part of the challenge is, and why this virus is so good at spreading rather than sort of being eliminated by killing its hosts, is it spreads. People spread it before they realize they've had it. And that's part of the logic of using masks.
Correct. And it's also probably the logic in the possibility or the availability of antibody testing eventually. Because as you pointed out, you may not have any symptoms at all for at least 5 to 8 days after you've been initially exposed. But you may, as you said, you have that inoculum, you have that viral load, but you're infecting everyone around you. So the thing is, getting that antibody test, finding out whether or not you have antibodies, socially distancing yourself, quarantining yourself are all important things to consider.
And I was thinking about, Justin, were you saying that you guys take your temperature when you go into the facility, right? But that's one of those examples where you say, well, that's useful for detecting symptoms for some people, but maybe not until they've already been contagious for 3 or 5 days.
Personal opinion, I think it's going to take a while. I think we're going to have to see how the next 6 months evolve. And here's a classic reason. We had, I don't know if anybody watches the Today Show, but it's a staple in my house. And they had their doctor, who's one of their representatives. I think his last name is Farrer. And he was the Ebola point physician in the Obama administration. And he related a story of where he was going to New Orleans. He was on a plane. The plane was packed. And this guy was in the ICU at one of the hospitals. He came down with COVID. And he attributes to it maybe getting in his eye when he was on the airplane. He said we were all close together. We were all, there were people coughing, people sneezing, so forth and so on. So the thing is, and here's a guy who's talking about Ebola, talking about COVID-2, COVID-1, giving us recommendations, and he inadvertently comes down with the disease, but was really taken aback by it. You could see the fear on his face as he was talking from the hospital. I mean, he's been since discharged in his home and is doing well, but I think it's going to take quite a while. Everybody forgets that there are other viral illnesses and that there are other medical illnesses out there, and we're concentrating on this one. So the thing is, we have to be careful in terms of personal things that we do in terms of boosting our own immune system to fighting these diseases. And that's a whole nother lecture that I'd be more than happy to entertain giving you. But I think it's going to take at least 6 months before we see how this virus declares itself even more, because it's not behaving. It's not behaving like a typical coronavirus.
Well, we're at 1 o'clock, and I want to be respectful of everybody's time. I really want to thank Dr. Acampora for making the time to do this on behalf of the whole Apex chapter. Thank you so much for hanging out with the supply chain crew.
Thank you. It's my pleasure.
Absolutely.
Dan, I just want to let you know that please pass on my contact info, my email address. If you want to give them my cell phone, go right ahead. I'll be more than happy to answer any questions that you may have. This is, as Dan knows, it's a passion for me to do this. So if I can help in any way, shape, or form, I'm available.
That's awesome. Thank you so much. Really.
Thank you.
Thank you, everybody, for joining for the May Apex Charlotte PDM. So we get our credit towards certification renewal in spite of the fact that we can't get together face to face. Whatever this looks like going forward, I look forward to seeing all of you again soon. And keep doing the great work that you're doing, because really, I mean, we're all counting on the supply chains right now, and this is the group of people that's making it happen and keeping civilization together in spite of the virus. So thank you, everybody.
Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you. Thank you.